Thank you very much. Thanks, David. It's a pleasure to be here and a pleasure to see such a big crowd on a wet and windy February night. So I'm going to just elaborate on a number of things that Professor Henschel has just gone through nicely for us. And I'm going to talk about a few more issues, obviously, that you may be interested in. I'm going to discuss a few things that might be a little bit surprising to you or a little bit counterintuitive. So we'll start. So first one is that we probably know, and for the rest of this talk I will use the term epilepsy and the term the epilepsies interchangeably, but we probably now should be using the term the epilepsies more often and replacing the word epilepsy. And I'm going to just extend David's definition of the epilepsies. So basically, the epilepsies can be defined as a group of neurological or brain disorders, I'll go slowly with this, affecting individuals or potentially affecting individuals of all age groups. So somebody can develop epilepsy right when they're born, they can manifest seizures, or it is also quite common, and this is not appreciated enough, that epilepsy can begin in late life. You can develop epilepsy in your 80s or 90s. So you can develop epilepsy at any age. It affects essentially both sexes equally. The epilepsies are of varying and often of unknown cause. I'll say a little bit more about that in a minute. Epilepsy traditionally is defined as somebody having the liability to experience recurrent, more than one, unprovoked, although clearly we know there are provoking circumstances for individuals, obvious ones being stress and sleep deprivation and missing medications, but characterized by recurrent, unprovoked seizures. And more recently, we are also conceptualizing the epilepsies if somebody has one unprovoked seizure, but on careful clinical analysis is found to have what we might describe as an enduring predisposition to further seizures. In other words, a high risk of having further seizures. And that can come out in factors in the history, but also if the brainwave testing is particularly abnormal, or if there's a particular abnormality on the brain imaging that would suggest to us that this individual who now only has had one seizure is at risk of having further seizures, then we may conceptualize this person as having epilepsy or early epilepsy. And the epilepsies may have, I think you just separated the paragraph, so I think actually we're okay with the colours, sorry. The epilepsies may have significant consequences for an individual and his or her family in terms of adverse educational, vocational, and psychosocial functioning, and also physical morbidity. By that we mean complications of treatment, complications of seizures, injuries, burns, etc., and potential mortality indeed. People with uncontrolled epilepsy particularly are at a higher risk of dying, either in accidents or suddenly in a very unfortunate phenomenon called SUDEP, or sudden unexpected death in epilepsy. So the epilepsies may have significant consequences in all these domains, and this is particularly true in the 33% of individuals who have hard to control epilepsy. And that's kind of the figure that is borne out in various international studies. If you take that there are 40,000 individuals in Ireland with epilepsy, or 50, 60 million people in the world with epilepsy, then 1/3 of those numbers will have drug-resistant, or what we physicians say refractory or pharmacoresistant epilepsy. So we're trying, we're giving drug A, drug B, drug C, and the individual is continuing to have epilepsy. And not surprisingly, they're the individuals in whom, generally speaking, all these adverse other consequences are more pronounced. Okay, so that's my more comprehensive definition of the epilepsies in a paragraph rather than in 3 words, which was previously many years ago, epilepsy is recurrent unprovoked seizures. We know now that it's much more than that, of course, and we recognize it's much more than that, including all the different comorbidities. It is frustrating for us as clinicians, and also frustrating for individuals and families, oftentimes, at least 50% of the time, that we can't explain why somebody has developed epilepsy, why they've just started to have seizures. We do know, of course, about some reasons why people develop epilepsy, And one of these important reasons would be an individual who's had a previous history of an early childhood neurological insult. What do I mean by that? I mean a young child or infant who has had recurrent complex febrile seizures, in other words, seizures with fever. I don't want to worry all the young moms and dads here, because most small children who have a febrile seizure, usually it's benign and doesn't really, it's not a harbinger of anything nasty that's going to happen later in life. But there are a small group of young children who have seizures with fever. They're either very long in duration, they're recurrent, or they're associated with what we call focal features, and those young children are at risk of developing epilepsy later in life. Other early insults to the brain would include meningitis or other brain infections, what we term encephalitis, where you get an infection of the brain rather than the brain covering, which is meningitis. Moderate to severe head injury is an important cause of epilepsy, and people who experience moderate to severe head injury will have about a 20%, a bit less maybe, risk of developing epilepsy over time. And one of the things that we don't understand in this setting, for example, is the process of epileptogenesis. By this I mean somebody can sustain a head injury at year 0 and develop epilepsy 10, 12 years later, okay? And we don't understand what happens in the brain over the course of those years, but it's a common clinical and epidemiological association. Not surprisingly, people who have brain tumors or brain lesions can have an associated epilepsy. Counterintuitively, it is more common to get epilepsy in people with benign, or if we separate it, it's arguable in these days whether we can do that in brain tumors, but more benign, what we call low-grade brain tumors rather than more malignant brain tumors. You generally get more epilepsy in the more benign brain tumors. And then you can get brain tumors due to other brain problems, vascular lesions affecting the blood vessels, common one of course being stroke, but other vascular blood vessel problems such as a tangled web of blood vessels that's presumably there since birth, and that can manifest as epilepsy at some point in life. So we do know a lot of the reasons why people develop epilepsy, but by and large, often we don't. And it is becoming apparent to us now in the last number of years that although I don't know how many of you have done leaving cert biology and leaving cert genetics, but basically it's becoming apparent that abnormalities in an individual's DNA is a cause, or at least a significant contributing factor to the development of their epilepsy. So we all, as you know, contain DNA in each of our cells. It's like basically the blueprint information in the cell that tells the cell what proteins to make. And the proteins, of course, we've many thousands of proteins, and they make us what we are individually. So there's the reading frame in the DNA, and then they're what we call in the business translated into proteins, and that makes us what we are. Not surprisingly, if we've got many DNA molecules, billions, the process is going to go wrong. It's probably surprising how it doesn't go wrong more often, and that leads to an abnormal protein, and that protein may be involved in important brain function. And if that protein is mutated, then the brain function will change, often in an adverse fashion, and that may cause hyperexcitability that we heard of, and therefore cause seizures. With these genetic causes, I'm not going to go through any individual genetic causes. Some of you may be aware of some. I'm happy to take questions later. They may or may not be a family history. It's also counterintuitive now that you can have a genetic disease, but it may not be hereditary. So how can you have a genetic disease if there's no family history? So there's a lot of work now going on in what we call de novo mutations or new mutations. So as the sperm and egg cell form the new individual, there may be an early misread in that machinery in the cell, and the problem may not be present in either parent, but is present in the young child or fetus from very early on. And these new mutations can cause new genetic disease, even though they're not, in the old-fashioned way, heritable. So this is becoming more and more an important cause of many epilepsies, and we're hearing about new mutations every month or so in the medical literature. And we are probably coming to the stage where we will be able to do a very detailed, I won't get into it, but a very detailed genetic test. It is called whole exome sequencing for those of you who are interested, but where we will be able to find more and more misreads, if you like, that will or potentially be a cause of an individual's epilepsy. And this is work that's been going on for the last 15 years, but this now is becoming available as a routine clinical test. It's becoming cheaper, it's becoming affordable, and it's also becoming cost effective because you rule out having to do a lot of other biochemical tests, for example. And this is sort of the new era of genomic medicine, and it's not just relevant to epilepsy, but it's relevant to other neurological brain diseases, and it's relevant to other diseases. So it'll be something that we'll be hearing more about. Of course, traditionally, the two main tests, the two main specific tests that we carry out in somebody with new diagnosis of epilepsy or in a suspected new diagnosis of epilepsy is both a brain scan, and usually that's a magnetic resonance imaging or MRI scan, and that's an example of an MRI scan on this side, cut like this, what we say coronally. So there's many pictures built up. Where we can see essentially the whole brain in different slices and different planes of view. And then on the left is the input from an EEG into an EEG machine, an electroencephalogram that's been around since 1928. It's essentially, apart from it gone digital, is essentially the same test that was developed by a gentleman called Hans Berger in Austria, who did the first EEG on his son. And this basically, whereas the MRI gives us a very fine detail of the brain's anatomy, the EEG gives us some insight into the brain function. Okay, so you're looking at anatomy and you're looking at function. Now remember, an EEG, which is carried out in a hospital like Beaumont or Tala, for example, is generally only a 30 or 40 minute snapshot in time. So it's very limited. Now, the more detailed investigation, I'm not going to talk about it here in any great detail, where we're, for example, looking at people being assessed for epilepsy surgery, those individuals have to be monitored with continuous inpatient video EEG for days and days, often up to a week, 2 weeks, before we will meet with Mr. O'Brien and colleagues and decide whether an individual would be suitable for surgery. So there's different levels of complexity in acquiring brainwave data. All EEGs are certainly not the same, and you can, even in one individual, an EEG on one day might show no information, diagnostic information, and you might do an EEG another day and it might show diagnostic information. And this is something, this slide just highlights, again, something that might be counterintuitive to you. The test, when I say the test, I mean an MRI and EEG, or an MRI or an EEG may be normal, and the individual still may have epilepsy. This is quite common, in fact. I'm talking now about routine EEG. And then the test may show an abnormality, so there may be an abnormality on an MRI, or there may be some abnormality on the EEG, and the individual may not have epilepsy. So when we make the diagnosis of epilepsy, it has to be made by a specialist, and it has to incorporate the clinical information and the intelligent interpretation of the investigations. Okay, so you're framing a picture. It's not just one piece of information. It's putting all the pieces of information together. Now, I was asked to speak about the patient journey. I think it was on the email I read. I'm not really going to speak about the patient journey, except we could just stay on this one slide for the whole night and tear it to shreds in Ireland and probably elsewhere. So the ideal timely patient journey would be where the individual who's just started developing epilepsy will experience symptoms, because you can just have symptoms or internal feelings, if you like. That's a symptom, something that the person reports to their doctor. Or they may have signs. That's something that you can see during the seizure. Patient family can see a behavioral change. So the individual experiences symptoms and or signs of their seizures. It's reported by the patient or observed by the family or both. The individual seeks medical attention, usually through the general practitioner. The general practitioner suspects this may be epilepsy and is referred to a specialist, who could be a pediatrician or a pediatric neurologist or a neurologist. And then they're seen by a specialist, and a diagnosis is formulated and tests are ordered. And even before the tests are ordered, the patient may be put on appropriate anti-epileptic medication. And then the patient becomes seizure-free without side effects. Oh yeah, that's fantastic. If it only were that simple. I mean, you could pick any line here and tear there's the obvious thing about resources and waiting lists and if you want to, we can talk about the shortage of neurologists. We've been talking about that since I came back, and we are still short of everything. And all the great things that we're hearing about the media when we're talking about emergency room waiting lists. I mean, there's the trolley crisis. The trolley crisis is only a symptom of the whole system. I mean, we are living older, which is great. But as you live older, you develop more diseases and more comorbidities, and the population is increasing, and the treatments of different diseases are getting better, and technology is increasing. So all that together puts a huge stress on the system that has never even really prepared for this. So the trolley crisis is a symptom of all that. It's nothing else. It's just, so we could take, for example, the second last line, appropriate medication started. So if a young 19-year-old girl develops epilepsy, for example, a type of epilepsy which is common in a 19-year-old girl called juvenile myoclonic epilepsy, and they're put on a medication called sodium valproate, epilum that is not an appropriate medication for a 19-year-old girl, because in 2017 we know that epilum is the most harmful drug potentially for a fetus in utero if that 19-year-old girl is going to get pregnant, or going to get pregnant 5 or 8 or 10 years hence. So there's a lot. We could spend the whole. I mean, I've only 15 minutes, probably up already, but you could spend 4 hours discussing this slide. I mean, be happy to, but well, not tonight. But okay. So there's a system developed over the years which is evolving called the classification, about a system from the International League Against Epilepsy, which is a group of professionals worldwide. A system developed and evolving, as I say, to classify epilepsies, or de-epilepsies, as I said at the start, and also an evolving and indeed new classification in terms of how we use language for the classification of seizures. Okay, so for example, one of the common types of of epilepsy in children, adolescents, and adults that we would see together with Mr. O'Brien, because these patients, when they're refractory, are the most amenable to successful epilepsy surgery, are individuals with temporal lobe epilepsy affecting either the right or the left temporal lobe. We've got one on both sides, obviously. So patients with a temporal lobe epilepsy may experience what is traditionally be called a complex partial seizure. If you're not medically trained or not trained in epilepsy, it's not intuitively obvious what a complex partial seizure is. So complex partial seizure is where a seizure that starts in one part of the brain and somebody has impaired awareness. Either they're not aware of their surroundings, or they can't remember what happened during the event. So that's a complex partial seizure. Now, the new classification for the new nomenclature for that is a focal seizure with impaired awareness. This is the new terminology for complex partial seizure. Somebody can have traditionally a seizure where they don't lose awareness, where they remain fully aware. For example, a rising epigastric sensation where the individual gets discomfort in the abdominal region, and they classically would say that the sensation rises up their body, and that's almost diagnostic for temporal lobe epilepsy. That simple partial seizure is now called a focal aware seizure. Okay, and where there's uncertainty, and there often is, whether there's impairment of awareness or not, we now should be using the term focal with unknown awareness. Okay, and these terms, I think I agree, are definitely better because they're more intuitive of what's going on. So focal with impaired awareness, focal aware, or if you don't know, say that you don't know, focal with unknown awareness. Now, the next slide, am I out of time already? Okay, because the next slide is really the most important slide in my view. And this is going to shock you. Well, maybe not. It won't shock some of you because some of you probably lived through this. Right now in Ireland and every other country in the world, there are people walking around who have epilepsy and are experiencing seizures and have not been diagnosed with epilepsy. This is extremely common. We see this all the time. There's a project in the States, which we are also involved in here, called the Human Epilepsy Project, where we're tracking people with newly diagnosed epilepsy. And it is exceedingly common that until the person has a grand mal tonic-clonic seizure and presents to the local emergency department that their epilepsy is, I'm not saying it's all the time, of course it's not all the time, but it's exceedingly common that people are having what we might euphemistically term minor seizures. Often they're not minor because the person is losing awareness, and nobody twigs that their that these are partial seizures, or in another epilepsy syndrome, myoclonic jerks. So you can have minor seizures, quote unquote. You can be having these for years and they go undiagnosed. Why do they go undiagnosed? Well, there's a number of reasons. The patient may not report them. If the patient gets a very strange experiential aura, they may say, well, I can't tell this to anybody. The person's going to think I'm losing it. The family may not realise that jerking they're seeing with young Emily having her breakfast every morning is abnormal, but that's just Emily, she jerks in the morning. The patient, they may end up going to the GP, but the GP, because he's not trained in epilepsy, may not recognise it, or if he hears about a rising epigastric sensation or tummy upset, he may refer to a gastroenterologist who then does an endoscopy into the stomach, which is normal, and they're sent back. I mean, I've seen this. I've seen it multiple times. So there are people walking around out there with active epilepsy who are not diagnosed, okay? And I would put it to patient organisations, including ourselves, put it to Epilepsy Ireland as well, that there should be a little bit like the stroke campaign, a little bit of a public awareness. Now, a very intelligent public awareness campaign. We don't want to generate anxiety, but there is a way probably of doing this. And as I say, when somebody has a convulsion, that's often when the diagnosis is made. Because of time, I'm going to sort of go through this fairly quickly. Some of this is, how do we treat epilepsy? Well, I think it's clear now we have to make the correct diagnosis. That's not a trivial issue. Lifestyle modification if appropriate. The patient, as I say to the patients, the drugs won't work unless you swallow them, okay? Now that sounds very condescending, but I mean, we try and get patients to take tablets once or twice a day, and if they're not happy taking them, then we have to discuss why aren't they taking their medication. If you as a patient or if you have a family member who's not happy taking their medication, well, they need to go back to their neurologist or their pediatrician and explain why they don't want to take drug A or drug X. Of course, there's always going to be difficulty in teenage years as well, so that's also a difficulty. We need to choose the right drug for a particular patient. That's easier said than done. If ongoing seizures, despite the use of 2 appropriate drugs or more at appropriate doses, then we need to think about whether this individual should be assessed for epilepsy surgery, or perhaps other treatments such as placement of a vagal nerve stimulator, or other treatments such as dietary treatments. Again, we don't have time to go through this. Everybody is different. And it is likely that what you read on the internet does not apply to you. Okay, you can read anything on the internet and it's likely that it doesn't apply to you. 2 patients with the same type of epilepsy may respond to the same drug very differently. One patient may become seizure-free without side effects, another patient may continue to have seizures with horrendous side effects, etc. Same epilepsy, completely different response. Treatment has to be individualized. This is a slide that's shown at every epilepsy congress multiple times, but it just demonstrates all the various drugs that have been developed over the last 20 years, and there are more being developed, but it's becoming more difficult for a variety of reasons to develop new anti-epileptic drugs. I said that I wouldn't get out of here alive unless I mentioned cannabidiol. So cannabidiol is a substance that's present in marijuana or cannabis. There's about 100 brain-active substances in cannabis. And it does appear that cannabidiol does, for some patients, have anti-seizure or anti-epileptic effects. It certainly has shown promising effects in some children with severe epilepsy or having multiple seizures every day. Cannabidiol is under investigation in adults. It's not available for prescription in Ireland, but it can be obtained as a food supplement, quote unquote. I'm not going to give it to you tonight as a food supplement. It is quite expensive. And also remember, when you read about cannabidiol in the Herald, or even the Irish Times, there is a publication bias. There's a publication bias in the medical literature, but there's an unbelievable publication bias in the Evening Herald. You are only going to hear about dramatic success stories. They exist, I won't deny it, but cannabidiol is not a treatment for everybody. I just saw a patient last week who is seizure-free, whose pharmacist said, oh, this is cannabidiol, it's a food supplement, you have epilepsy, you should take it, and they sold it to them. I mean, this is patient seizure-free. So this is getting out of hand. We've got to rein it in. I'm not saying it doesn't have a place, but it's getting out of hand. And it can also interact with other medications. Last slide. This is a very difficult issue for all of us, both those of us treating people with epilepsy and for, of course, individuals and their families. But the essential rule for Group 1 vehicles, by that I mean essentially a private motor car, is that a patient needs to be free of any functionally disabling seizures. And we're not talking just about tonic-clonic seizures, but any seizure that would impair functioning. Now, I often ask patients if they're having partial seizures and I'm unsure whether they're aware or unaware, because sometimes patients, it's hard to tell. And I'm often saying, well, I can pull over, doctor. Now, I tell you, driving the M50 these mornings on 3 or 4 lanes, and if you're in the middle lane, you've got 2 Eddie Stowbar trucks on either side of you, you ain't going to be able to pull over, right? So that's not an excuse. Okay, so you have to be seizure-free of functionally disabling seizures for a period of 1 or more year. You can drive on medications. There can't be no other issue like visual problems, not difficulty seeing to one side, which will debar you from driving. There are some exceptions, so if somebody has a continuous pattern of sleep seizures only for more than 1 year, then that person can drive if the neurologist agrees. And first seizure can be tricky, but it's at least 6 months, and if there are abnormalities on MRI or EEG that we're worried about, it's a year. And finally, maybe we won't need to worry in a few years when Google and Volvo and Tesla Motors get their act together and we'll all be driving around in self-driving cars, so that the individual epilepsy will get into the car and say, take me to Tesco. Okay, thank you very much.